To perform an examination of any body joint, we use these steps: look, feel, move, and perform special tests, depending on the joint being examined. To perform a complete shoulder exam, follow the following steps. Wash your hands, introduce yourself and confirm patient ID. Position patient and ensure privacy. Explain the examination and take consent. Expose the whole upper trunk and compare both shoulders. Look. Look at the front, sides, and back. Compare both right and left shoulders. Note any skin changes, erythema, deformity, scars, swellings, or muscle wasting. Let's do a quick review of surface anatomy before moving on to palpation. Coracoid process: sternocleidomastoid, clavicular head, and sternal head. Clavicle, sternoclavicular joint. Acromion, acromioclavicular joint. Deltoid, biceps, pectoralis major. Spine of the scapula, medial border of the scapula, supraspinatus, infraspinatus, and teres minor. Alignment. When viewing the shoulders either anteriorly or posteriorly, shoulders should appear symmetric. Assess alignment by drawing an imaginary line between paired landmarks, such as the acromioclavicular joints. The line should be horizontal. Assess for winging of the scapula by asking the patient to stand up and lean against the wall. Winging of the scapula is a sign of paralysis to the long thoracic nerve supplying the serratus anterior muscle. Feel. Warm your hands before touching the patient, and always ask if they're in any pain. To assess the temperature, rub your hands together to warm them. Place the back of your hands on the joint. Do this bilaterally to compare both sides. Palpation. Palpate for tenderness and crepitus. Palpate the anterior, lateral, and posterior regions. Look at the patient's facial expressions as you do this. Palpate the sternoclavicular joint, clavicle, acromioclavicular joint, acromion, coracoid process. This is the acromioclavicular joint and acromion. Spine of the scapula, medial border of the scapula, inferior border of the scapula, supraspinatus, infraspinatus, teres minor, trapezius, deltoid muscle, and the long head of the biceps tendon. Move. Start with active movement. Don't forget to comment on the range of movement and compare both sides. Abduction. To evaluate abduction, ask the patient to bring both arms up to the sides as far as possible until the arms are straight overhead. If there is any pain or inability, then move on to passive movement. Ask the patient to relax as you move their shoulders for them. Forward flexion. Ask the patient to lift his or her arms forward in the sagittal plane as far as possible. Extension. Ask the patient to swing upper limbs as far posteriorly as possible while keeping the elbows straight. External rotation. Ask the patient to place both arms firmly against the sides and flex both to 90 degrees. Neutral is 0 degrees. Rotation is present when the forearm is pointed directly forward. Now ask the patient to rotate both forearms as far as possible while keeping the elbows as firmly against the sides of the trunk. Internal rotation. The best way to assess internal rotation is by the Apley scratch test. Ask the patient to reach behind his or her back. Identify the highest vertebra the patient can reach. Normally, the patient's shoulder should reach the inferior border of the scapula. Internal rotation is usually the first motion lost in adhesive capsulitis. To assess the integrity of the supraspinatus muscle, perform the empty can test. Ask the patient to abduct the arms extended to 30 degrees and internally rotate them with the thumbs pointing down. Push the patient's arms down against resistance, looking for weakness or pain, which would indicate supraspinatus muscle injury. To assess the integrity of infraspinatus in the teres minor to a lesser extent, perform the resisted extension rotation. Ask the patient to flex his or her elbow to 90 degrees, while the arm is by their side. Next, apply maximal external rotation force on the arm. Ask the patient to maintain this position and release your arm. In a normal exam, the patient should be able to maintain the arm in the maximally externally rotated position. If the arm drifts backwards, it indicates significant damage to the infraspinatus tendon. To assess integrity of the subscapularis, perform lift-off test. Ask the patient to internally rotate the arm behind the back to the mid-lumbar region. The dorsum of the patient's hand should rest on their back. The patient is then asked to lift their hand off the back. Inability to do this is a sign of subscapularis rupture. Subscapularis strength can also be evaluated by asking the patient to hold the arm in the lifted position while the examiner tries to force the patient's hands towards their back. This is called the belly liftoff test. To check for presence of impingement syndrome, perform Neer's test. Passively flex the patient's shoulder to maximal forward flexion while stabilizing the patient's scapula with the other hand. If the patient experiences pain, this is a positive test indicating impingement syndrome. Another way to check for the presence of impingement syndrome is Hawkins' test. Ask the patient to forward flex their shoulders to 90 degrees with the forearm parallel to the floor. The examiner then passively internally rotates the shoulder while keeping the arm in the forward flexed position. If the patient experiences pain, this is a positive test indicating impingement syndrome. To check for anterior shoulder instability, perform the apprehension test. The test may be performed with the patient standing or sitting. The examiner asks the patient to relax and places the patient's shoulders in 90 degrees of abduction and slight extension with the elbows flexed. The examiner then externally rotates the arm. A positive test is when the patient reacts by expressing concern or anxiety, or even preventing movement. It can also be performed with the patient lying down in a supine position. Finally, to complete the shoulder examination, you should perform a neurovascular examination and examine the joint above, the cervical spine, and the joint below, the elbow.